Anterior oblique ligament, an anatomy dissection. We have no relevant disclosures. For a correct anatomy dissection, the first step is to turn the leg with the medial side facing you and draw a hockey stick-shaped line by following the femoral diaphysis to the medial epicondyle and the tibial diaphysis. Carefully make an incision along this line, cutting through the skin. Once the skin is incised, remove underlying fat tissue and gently reflect the skin on both sides as if opening a book to expose deeper structures. Identify the medial fascia and the fat tissue in popliteal fossa and find the borders between them. Identify the medial condyle by sight and touch, and find the anterior oblique ligaments attachment and posterior oblique ligaments attachment. Both ligaments are extracapsular. With external rotation, anterior oblique ligament gets tight, and with internal rotation, posterior oblique ligament gets tight. Pin medial condyle and superficial medial collateral ligament distal insertion. Identify the medial cross, which consists of the medial condyle and distal insertion of superficial medial collateral ligament, anterior oblique ligament, and posterior oblique ligament, responsible for valgus stress and rotational stability. Carefully separate AOL and POL. You can separate the AOL before detaching the superficial MCL. Detach the first distal attachment of superficial MCL, most robust attachment. After releasing the distal attachment, observe the interattachment bursa structure. After the distal attachment, interattachment bursa, tuberosity, and proximal attachment are observed. Note that the semimembranosus muscle attaches just posterior to the tuberosity. In some cases, this muscle may need to be cut to proceed. As you continue to dissect the superficial MCL proximally, be aware that separating the superficial ligament from deep MCL can be challenging due to potential adhesions between these structures. Finally, the soft tissue between the deep MCL and the AOL should be identified, and these two ligaments should be differentiated. Note that the AOL is an extracapsular structure. In this simulation, we observe the AOL being tensioned when there is external rotation of the knee. Thank you for following this dissection.